Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Welcome to all of you who are able to join us tonight during our Lung Cancer Living Room. For those of you who may not know me, I'm Danielle Hicks. I am Chief Patient Officer here at GoTo Foundation for Lung Cancer. And for those of you who may be new or not familiar with our Living Room program, it's a support and education series created specifically with people living with lung cancer and their loved ones, their caregivers in mind, with the goal of really bringing to you live and in real time educational talks from key opinion leaders in the lung cancer community, and in a format and a language that's easy for you to understand. So we know that people watching tonight come from around the globe and consist of people living with varying types of lung cancer and undergoing various types of care. We want you to know that we are here for you and that we believe wholeheartedly that educated and empowered patients just do better. So thank you for joining us. Tonight, we're going to be talking about treatment options for late stage lung cancer, non-small cell and small cell late stage lung cancer. And we are so honored to have Dr. David Gerber, who is Professor of Internal Medicine and Population and Data Sciences, David Bruton Jr., Professor in Clinical Cancer Research, Associate Director of Clinical Research, Harold C. Simmons Comprehensive Cancer Center at UT Southwestern Medical Center. I'm going to give a little brief introduction to what we're going to talk about tonight, and then I'm going to ask Dr. Gerber to do a little better a job than me just reading off some pretty fancy titles there. But before that, as I said, there are many different types of treatment options for lung cancer patients, non-small cell and small cell lung cancer alike. There are targeted therapies, immunotherapies, chemotherapies, radiation therapy, and combinations of these therapies. I think one of the most important things that we're going to cover tonight is that it's how very important it is that proper upfront diagnostics are done, specifically around comprehensive biomarker testing. So we're going to start with a little bit of that. Before we get into all of that, Dr. Gerber, I'm going to switch to you and ask you to just give us tell us a little something about yourself and why you chose lung cancer as a primary area of focus. Welcome.
Sure. Well, Danielle, thank you so much for the invitation. This is not my first time being part of a living room event, but it is my first time being involved in a virtual one. And I look forward at some point to seeing you and others in person, perhaps the next time that I'm involved. I picked lung cancer as a specialty area for a couple of reasons. Number one, when I was finishing my training, which was well over a decade ago, it's hard to believe. To me, it seemed like an area that was at an inflection point, that treatment and outcomes had not changed much for decades, but it looked like the research and the developments, they were catching fire. And I thought it was a really exciting time to be part of a field, and especially as someone who thought he'd be pursuing research as part of my career, it fit in really well. And finally, I have to say that I've always felt it's been a true honor and pleasure to be the physician for individuals going through a lung cancer diagnosis and treatment. It can be very challenging, whether it's the disease itself or the complexities or toxicities of treatment. And for individuals to put their faith in me and to share that experience with me is a real honor.
Thank you so much for sharing that. And number one, thank you so much for participating in past lung cancer living rooms. I think Michelle and I were out in Dallas and we did one of our regional meetings from there in this amazing venue. So we hope to either be back out in Texas again and have you on live, or have you come out here to California and join us in the living room here. And number two, I love your shirt. So I'm really
Thank you.
excited that you're presenting Go-To tonight. So thank you for
I
that.
think I got it at Saks Fifth Avenue.
I think you might have. I think you might have. All right. So I know that time is, limited tonight, and that we only have about an hour to discuss the many, many varying options for people who are diagnosed for lung cancer. But I do want to start with talking a little bit about biomarker testing. And I know those watching who are veterans to this program have heard us talk about this in the past, but I don't think we can focus on this enough, because there are still many people out there who aren't receiving this, upfront diagnostic to ensure that they are getting the best treatment for their specific lung cancer. So, can we start a little bit by just explaining what a biomarker is and what we're looking for when we test for them?
Yeah, so outstanding question. And I think one of the reasons why it may seem so confusing, and confusing not only to patients and their families, but confusing to advocates and clinicians and trainees, is that biomarker is a really, really broad term. And the way that I think about a biomarker is it's some sort of information that characterizes, well, for me as a physician, a disease. Um, and it's not just used in cancer, it's used in other fields. So, for example, if a patient goes into an emergency room with chest pain, a blood test can be sent looking for a biomarker, telling the medical team, was this a heart attack? Yes or no? That's a biomarker. In oncology, biomarker testing goes back decades. So, for example, in breast cancer, once it's diagnosed, a pathologist helps us look for the presence of estrogen receptors and progesterone receptors to let us know if we can use hormonal therapy to treat the breast cancer. Those are drugs like tamoxifen. In lung cancer, it's been a much more recent development. And even within this one disease, biomarker testing takes on different forms. Sometimes it's done on tissue, sometimes it's done on the blood, sometimes it's a very straightforward test where the pathologist just does it around the time of giving the initial diagnosis. And sometimes it's more complex, where it's not done by the local pathologist, but it's sent out to a lab to do molecular profiling. And that's also a confusing term, because sometimes we call that genomic testing. We're looking for mutations, we're looking for alterations. Sometimes you'll hear people talk about looking at the DNA or the genes of the cancer. We have to be really careful not to confuse this testing with what we traditionally think of as genetic diseases. Lung cancer is almost never a genetically inherited disease, but as we all know, there are genetically inherited diseases like sickle cell disease or cystic fibrosis. Biomarker test results can give us different information. Sometimes a biomarker can give us a diagnosis. Sometimes a biomarker can give us prognostic information, maybe let us know how aggressive a cancer might be. But what's most helpful for healthcare providers is what we call predictive biomarkers. And a predictive biomarker is a test that gives us a suggestion of what treatments to use and what treatments not to use. When we do molecular testing on a lung cancer and it's sent out to another lab, often besides the hospital that did the diagnosis, sometimes it takes a couple of weeks for that information to come back. But depending on that information, it can give us results where it's a very clear yes or no which treatments we should use. And that's pretty rare. in clinical medicine to have something so clear like that.
That's a great, great explanation of what biomarker testing is. It's sort of, I've heard the analogy used before of, if the cancer is the bus, right, you want to know who's driving the bus. And so if you can identify some of these markers that have approved targeted therapies attached to them, if you will, then you know which therapy is the right therapy to give the patient. So, Dr. Gerber, who today should be getting biomarker testing? I know tonight we're talking about non-small cell and small cell, but as of today, what does this testing look like, and who should be receiving it?
Yeah, so I think we need to think about it both in terms of the types of lung cancer and the stages of lung cancer. For both small cell lung cancer, which is about 15% of lung cancer, and non-small cell lung cancer, which is 85% of lung cancer, the staging system is pretty similar. Stage 1 is just a tumor in the lung. Stage 2 is often a tumor plus some lymph nodes nearby that have cancer in it. Stage 3 is cancer that's a little more advanced in the chest area, and stage 4 usually means the cancer has spread outside of the chest area to other organs. I bring this up because if you had asked this question 2 or 3 years ago, I would have said, well, regardless of the type of lung cancer, we only use this information for people with stage 4 lung cancer. And that's no longer true. That's a recent development, that now this information may inform our treatment decisions even for stage 1, 2, or 3 lung cancer, where we still may rely on treatments like surgery as the initial treatment, but depending on the biomarker test result, we might offer someone what we call targeted therapy after the surgery and other treatments are finished. Now, the question about which types of lung cancer, that's a little bit more tricky. For the most part, when we talk about biomarker testing being molecular profiling, in small cell lung cancer, we don't have approved treatments that are based on those results, but there may be clinical trials that require that information to evaluate a patient for an enrollment. Um, when someone's in a situation where biomarker testing isn't required for their management, and there are cases like that, we want to think carefully about whether it should be ordered. And there are a couple of caveats. If it's not normally indicated, the patient may be asked to pay for it rather than the insurance, and that can be thousands of dollars. And if there is only a certain amount of tissue available, if we send it for molecular testing for, say, an initial small cell lung cancer diagnosis, when we need that tissue for another question later on, it might not be available. But the reality is that for most non-small cell lung cancer cases, even early stage cases now, having this information might be something that's used not only in the future, if the cancer comes back or recurs, but even after initial treatment.
Yeah, I think it's important to point out. It's a very important point. The early stage targeted therapy space is fairly new, the last year and a half or so, where we've
Yep,
actually had some great options, particularly in the adjuvant or post-surgical
that's right.
arena for early stage patients. When we're looking, though, I kind of think about targeted therapies, and I'm saying this in particular for our small cell folks who might be watching, because I think you touched on a really good point where we've come in the last 15 years or so in the non-small cell space with targeted therapy is due to patients participating in clinical trials, getting this biomarker testing, identifying biomarkers, and then looking, enrolling in studies that are looking at drugs that could target these biomarkers. And the same thing is happening now in small cell. So I think it's an exciting time. Not that it's ever an exciting time to be diagnosed with lung cancer, because it most definitely is not. But there are so many things coming down the pike, particularly for small cell lung cancer patients, who are the smaller sort of minority of folks diagnosed every year with lung cancer. But it has historically been one of the harder lung cancers to treat, right? With not a lot of good new options to treat. So I think it's important that patients who are diagnosed with small cell are having those conversations with their physicians about the potential for clinical trials and when might be the good time to do that. Um, I don't want to belabor that too much, because we're going to get into some of the treatment options as we talk a little bit further. So we've talked a little bit about this biomarker molecular genomic testing. And historically, I think doing this type of testing on tissue has been, and still is, the gold standard. But liquid biopsies have very fairly recently, over the past few years, sort of entered the scene as a potential good option as a supplemental or companion diagnostic. Can you talk a little bit about when a good time maybe to use a liquid biopsy would be, what it is,
Yeah,
and when?
so just to clarify, liquid biopsy refers to a blood test. So the experience for the patient is no different than getting your blood drawn to see what your blood counts are after chemotherapy, or to see what your kidney or liver function is. And it's really an incredible, incredible technology. And this technology wasn't first applied to people with cancer. It was first applied to pregnant women to test for genetic diseases. So, up until about 10 years ago, if, someone wanted to evaluate if a pregnant woman was at risk for having a child with a genetic disease like Down syndrome, the only way to know was by putting a needle into the uterus to sample that area. And then all of a sudden, technology emerged where a blood test in the pregnant woman could figure out which DNA or which molecules in the mother's blood were coming from the fetus. And when you're pregnant, about 12% of those molecules in your blood are from the fetus. Well, it's harder in cancer, because in cancer, even if you have widely metastatic cancer, less than 1% of the molecules in your blood may be the cancer's molecules as opposed to your own molecules. But our technology is so good now that sometimes we are able to detect those molecular abnormalities from a lung cancer through a blood test. And when we use a blood test versus tissue, I think that's a widely debated question. Oftentimes, when people have been recently diagnosed, um, I have the tissue available. I know that I'm kind of evaluating other aspects of the cancer as I plan treatment, like confirming the stage of the cancer. And so I think I've got access to the tissue and I have time. I'm probably going to start by sending the tissue, because in general, even though the technology with the blood tests has come a long way, that test often is not as sensitive as looking at the tissue, meaning it just may fail to detect a mutation or a meaningful result, even if it's there. The thing about molecular testing, whether it's tissue or a blood test, is that while sometimes we can see false negatives, like a blood test that just doesn't have enough sample in it to find it, it's rare to have a false positive. So, if I run a test on tissue or I run a test on blood and it shows that I've got a mutation that tells me the Achilles heel for the cancer, tells me what targeted therapy I might use, I'm usually not questioning that result. Now, are there times when I might prefer to do a blood test? Well, let's say I don't have enough tissue available to send the tissue test. If I think that it's going to take a long time to schedule or get the results, or it's going to be particularly risky or painful for a patient to do a biopsy, I might do a blood test at that point. And there are other times when doing a blood test might be really helpful. And this is also a relatively new development in our field. I think, up until about 5 years ago, doing the molecular profiling before we selected what we call targeted therapy was really helpful. But once we gave a targeted therapy, doing more molecular testing didn't give us any new information. But now we've got so many new treatments that are effective for cases that become resistant to the initial treatments, that doing new molecular testing to see what's changed can be informative. And sometimes doing that with a blood test can be particularly timely and feasible, because I can see a patient on the same day that a CAT scan showed disease progression, and in clinic after our conversation, we can draw that blood test and get that result back in about a week. As opposed to at that point, me scheduling a biopsy, the biopsy being done, the tissue sent to the lab, then the tissue sent from the lab to the molecular diagnostic center. You can see how sometimes doing the blood test can be more convenient.
So I want to recap, and then I have a question. So tissue still sort of gold standard, and I just want to make sure that our audience understands that what you're saying is these liquid or blood-based biomarker testing options, if something is not seen or not picked up in one of these blood-based diagnostics, it doesn't necessarily mean it's not there. In other words, doing the tissue, if we don't see it, we can be fairly certain it's not there. If we do see it, we know it is there. So that's kind of the difference between what the how specific these tests can be. So you mentioned something about progression, and I think in particular for those who have a biomarker upon diagnosis, and I'm curious, and this isn't something we talked about beforehand, but in my own head it just kind of popped in. At progression, is doing a repeat test helpful in determining whether it might be what we call oligometastatic disease versus true progression, or does that play a role at all in that setting?
Yeah, so when I think about the term oligometastatic, in my mind, that doesn't refer to the molecular characteristics or the subtype of the lung cancer. It refers to the location of the lung cancer and how much there is. So I referred before to stage 4 lung cancer, or what we call metastatic lung cancer, usually meaning that the cancer has spread outside of the chest. Now, it's possible that the cancer could have spread to one spot outside the chest, just a single organ site, or there might be 20 spots, different bones, the liver, the brain. And if someone has very few areas of cancer, even if it's technically metastatic, we call that oligometastatic, oligo meaning few. And we may approach treating that patient's cancer very differently. We may start to think about what we call local treatments, which specifically are physically aimed at a cancer, whether that's a surgical resection or radiation, either instead of or in addition to our medical therapies.
That's helpful. Thank you. So before we jump into what exactly a targeted therapy might look like for those who have an identified biomarker, in your opinion, how important is it that patients wait for this biomarker testing before starting treatment? Because I know there's a lot of concern, or we get a lot of, you know, patient comments around the time to test from the time to treatment quite often is 3 weeks, maybe even longer, particularly on tissue. And they're concerned about waiting that amount of time. Can you talk a little bit to the importance of that in spite of the wait, or when you might not want to wait?
Yeah, well, I can't imagine how hard the waiting is. It's interesting that in a disease like breast cancer, and I talked about the biomarker testing that's done in breast cancer to see if hormonal therapy works. That test is not ordered by the oncologist. Those tests are automatically ordered as soon as lung cancer, or as soon as breast cancer is diagnosed. It's just done reflexively by the pathologist. So when a patient arrives in the office of the medical oncologist for the first visit, that result is available. But that's rarely the case for lung cancer, and there are a lot of complex explanations for that. I've tried to think through with my colleagues, both at my institution and nationally, but is there a way in our field to make it an automatic process? So instead of the medical oncologist deciding to start the process is already finished when a patient sees a medical oncologist for the first time. I don't know if I'll ever be able to make that change, and we could spend a whole 2 hours talking about why that is. When I think about what it means to wait for the results, that's going to depend on a couple of things. It's going to depend on how likely I think the results are going to be helpful and make a true difference compared to something else I would choose. And it's also going to depend on how dangerous I think waiting that time will be. Let's start with that second issue. I think it would only be in rare cases that waiting, let's say the window for the test results is 10 to 14 days on average for a tissue test that's ordered the day the patient has the initial visit with the medical oncologist. In the majority of cases, a cancer is probably not going to grow or spread significantly in 10 to 14 days. But that's not the only issue. The reality is that I've never been told that I've had lung cancer. I've never had a lung biopsy. I've never had to have a brain MRI. I can't imagine how stressful it is knowing there's more waiting time. And there are times when the psychosocial stressor of the situation is equally, if not more important than the physical things that we're focused on. What do I mean by the likelihood that I think the answer is going to make a difference? There are certain characteristics of cancers and patients that make me think identifying a targeted therapy is highly likely. Remember that currently, I would say about 25 to 30% of non-small cell lung cancer patients will ultimately have one of these found. That's double the percentage that I probably would have quoted to you 5 to 10 years ago, right? We keep finding new targets and new drugs for those new targets. And, there are cases where, what I call my pretest probability, my suspicion that we're going to have a positive result is over 75%. And there are cases where my suspicion is under 10%. And then it is especially helpful if I think a targeted therapy, if I find it, is going to offer a huge treatment advantage. So if I have a patient with multiple brain metastases, where the standard treatment would not be focused radiation, but whole brain radiation, which is 10 treatments over 2 weeks, has side effects near term and long term. But if I have a targeted therapy, that's a pill that someone takes each day, might be as effective as the radiation. That's really great information to have. Now, you can think, though, that if you have a situation where someone has multiple brain metastases, that's also a situation where we might be a little more reluctant to wait. So it's a give and take, which is why I think each case is different. So it's not that a good oncologist will say something versus a bad oncologist. I may have advice to one patient at a visit at 10 o'clock in the morning, and I see another patient at 1 in the afternoon, and my advice is different just because there's so many factors that go into making these decisions. But I do think that it's got to be a discussion, and that if there's a recommendation not to wait or a recommendation to wait, there has to be an explanation for that recommendation. There does.
Yeah, I love the discussion piece of this, in particular, where, healthcare providers are taking the time to have these conversations with the patients walking through the door and their caregivers or loved ones or whoever may be there with them, because it, to your point, is such a complex disease. As we know now that we didn't necessarily know 20 years ago, it's many diseases, right? And it's, I think, to your point, why it is so um, incredibly imperative that you are ensuring via biomarker testing and with all of these other things that you just discussed, having that conversation with your physician to determine what the best treatment is for you. I'm always, as always, keeping my eye on the clock, and we've got a lot of things to talk about outside of even biomarker testing and targeted therapies. And I think we've touched on the targeted therapy piece in that if a biomarker or uh, mutation is identified in the testing, um, there are several biomarkers that have approved therapies to target for them. Like you said, most of which are in pill form. Some, particularly when I think about KRAS, G12C, even more particular to that, where KRAS is sort of a big, if you envision lung cancer, non-small cell anyway, as this pie, this sheet of pie, it's slivered off into all of these different subtypes. And KRAS tended to be the largest sort of piece of the pie. And now so many incredible things that weren't really there before for these patients are starting to come down the pike. And it's a very exciting time, I think, for all of them, not just at diagnosis, but upon progression, to your earlier comment about um, these these drugs that are coming down further down the pipe from even some of the original ones. I do want to jump though into immunotherapy, because I think it's an important sort of new kid on the block, so to speak. I think a lot of pharma companies have done a really great job with this direct to consumer marketing, and I think patients, when they are diagnosed, most of them have probably seen the commercials and think, "Oh, that's what I want. I want immunotherapy." Can you talk a little bit in the non-small and small cell lung cancer space about what immunotherapy is and when it's an appropriate treatment, and how we determine whether or not it's an appropriate treatment?
Yeah, well, and I'll tell you, Danielle, the marketing piece is a really important part of this discussion, because when I do prescribe immune therapy for someone and we go through the schedule and we go through the potential side effects and the monitoring, oftentimes the last thing that I tell them is that one of the greatest potential risks of immune therapy is disappointment. And that is, it's an incredible treatment, one of the greatest advances in oncology. When we think about some targeted therapies only being relevant to 1% of lung cancer cases, but immune therapy being potentially used in all non-small cell lung cancer, all small cell lung cancer, all kidney cancer, all liver cancer, all lymphoma, you can see how huge an advance it is. But it doesn't work in everyone. It doesn't. And I will just tell you anecdotally, I had a patient who drove 5 hours to see me from West Texas who had stage 1 lung cancer. And she had gone to a surgeon who said, I can take it out. And she came and said, Dr. Gerber, I can't believe they want to do surgery on my stage 1 lung cancer. I should have immune therapy. And I had to remind that person that in a case where we can cure cancer with surgery, that's the best thing we can do. But back to immune therapy. The idea of immune therapy is not new. in cancer. And there are drugs that have been around a long time for other diseases, not lung cancer, that have been relatively effective and approved. So for diseases like kidney cancer and melanoma, we have IV infusions that we call cytokines that stimulate the immune system. Some of them are really dangerous treatments, and we have to put people in the ICU to give them. In a way, a bone marrow transplant for leukemia is a form of immune therapy because we're giving someone new immune cells in that new bone marrow. And those immune cells weren't getting used to the leukemia before. They're brand new and they're ready to attack. But when we talk about immune therapy in 2022, and especially when we talk about it in lung cancer, we're talking about drugs that we call immune checkpoint inhibitors. And think of those drugs as taking your foot off the brake. All of us have brakes on our immune system. If we did not have brakes on our immune system, we would all have autoimmune diseases. Maybe an autoimmune disease that attacked our skin, psoriasis, an autoimmune disease that attacked our joints, rheumatoid arthritis, an autoimmune disease that attacked our intestine, like Crohn's disease. And there's still tens of thousands of people who have those diseases. But when our immune system has all these checks and balances in place, it doesn't get a chance to react as well against something foreign, like a tumor that shouldn't be there. And these drugs in some people with lung cancer can work incredibly well. And sometimes they even lead us to think that people with stage 4 lung cancer might be cured of their cancer. And that's something that we did not say when we had chemotherapy. We did not say with targeted therapy, but now we may be seeing it with immune therapy for the first time.
Yeah, I think it's really interesting. I remember this was a few years back um, when this type of therapy was first sort of being approved and breaking into the scene, if you will. And we had a physician on who kind of gave this analogy of cancer being the foreign object in your body, right? It does not belong there. It's not something that is supposed to be there. Being similar to a woman being pregnant, right? And the pregnancy, your immune system, whatever those synapses or whatever you're talking about that are turned off so that a woman's own body doesn't attack her fetus are similar in cancer cells. Like the cancer is smart enough to hide from the immune
That's
system.
right.
So some of these new drugs come in and they kind of open the kimono, if you will, on the cancer. So your own immune system can virtually say, aha, I see you and here I come.
Yeah.
Fair?
And immune therapy has, like I said, the potential for widespread benefit. What does it mean to get immune therapy? Oftentimes, so these drugs, if we're going to really refer to the drugs that I call the checkpoint inhibitors, they're always given IV. So far, we just don't have any drugs very far along in development that fall into that class that would be given orally. Sometimes they are given with chemotherapy. Sometimes they are given after chemotherapy. Sometimes they're given after radiation. Sometimes they're given by themselves. Sometimes they're given in combinations of more than one immune therapy drug. Now, not in lung cancer, but in kidney cancer, there are approved combinations of targeted therapy and immune therapy, a targeted therapy pill and an IV immune therapy. Those combinations have been studied in lung cancer. So far, none have been particularly effective, and some of them were exceedingly dangerous, and the studies were stopped shortly after starting. We talked about the use of biomarkers, especially for targeted therapy. And, there are scenarios where I can get a biomarker result and know that if the biomarker result is negative, the chance of the targeted therapy working is 0%. And if the biomarker is positive, the chance of the targeted therapy working is over 90%. That is an incredibly useful test. That is not true for all targeted therapies in lung cancer. With some of them, a positive result may mean that the available targeted therapy has a 50% chance of working. It's not always 90%. But remember that when it comes to medical therapies for lung cancer, we're not giving these treatments for years at a time without checking our progress, right? Oftentimes we're starting it, maybe visiting with the patient 3 to 4 weeks later to see how the side effects are, draw some blood to look at how it's tolerated. And then often within 6 to 8 weeks, maybe 9 weeks, getting a follow-up imaging study to see if it's working. And then we really know whether we're going to be doing it longer term. What about the biomarkers with immune therapy? They're not perfect. If you have a really positive result, it may tell you that immune therapy by itself has about a 50% chance of really working. But if the result is entirely negative, immune therapy by itself may have a 15% chance of working, not 0. And we also know that immune therapy may be helpful when combined with chemotherapy, regardless of any immune therapy related biomarker testing for both small cell and non-small cell lung cancer. So we're using these drugs more and more and more. And just like with targeted therapy, if you had asked me this question 2 years ago, I would have said immune therapy is only for stage 4 lung cancer. But, a couple of years ago, it got approved for stage 3 lung cancer. And then 6 months ago, it got approved for surgically removed early stage lung cancer. And there are options to give it both before surgery or after surgery.
Yeah, which is wildly important to these combination therapies, these therapies that were typically sort of saved, if you will, for the later stage patients now be using in early stage, is a very important piece of this, particularly because we know that historically as well, in spite of surgical resection, quite often lung cancers would come back, right? So why? What does that look like in the
Right.
pre-surgical and post-surgical setting? How can we kind of help wipe out any potential rogue cells? I want to jump to a couple of questions from the online audience before we finish up with chemo and radiation, which tends to be sort of a taboo subject for a lot of patients diagnosed because they feel like, man, I can't get a targeted therapy or an immunotherapy right now, and or I've progressed and my best option is chemotherapy. People tend to get a little concerned about it. But before we jump there, um, a question came in regarding our earlier sort of piece of the conversation about how do you manage patients with a lung tumor, but the immunohistochemistry and genetic testing can't identify if it's a primary or metastatic disease. How would that typically
Yeah.
be managed?
So I mentioned before that biomarker testing can have a couple of roles. It might be predictive, telling us what treatments are going to work and which ones aren't. Prognostic, telling us how aggressive a cancer is going to be. And sometimes diagnostic. And it turns out that when pathologists look under the microscope at the size and shape of cancer cells, cancer that starts in the breast or the colon or the lung actually look very similar in the microscopic appearance. And so the pathologists do special stains on the tissue, immunohistochemistry, to try to tell them apart. The reality is that in lung cancer, maybe those types of tests are positive and truly distinguish a lung primary tumor from a tumor that's spread to the lung in about 70% of cases. So that means 30 or so percent of cases, the immunohistochemistry doesn't give the answer. And we as medical oncologists recognize that, and we put all of the information together to use our best judgment. So for example, if someone has a spot in the lung that looks like a perfect circle, that to me is more likely to suggest a metastasis than something that is more spiculated or has some spines around it, not a perfect circle. But that's not always the case. What if someone has spots in the bone and spots in the lung? Well, in adults, having a primary bone cancer going to the lung is much, much less common than a cancer going from the lung to the bones. Same with the liver, much more likely to go from the lung to the liver than vice versa. And if there are tumors in the brain and in the lung, I'm just not aware of any cases of primary brain tumors that would go to the lung. So it's taking all of this information and putting it together it's the radiology, it's the patient's history, it's the pathology. And then sometimes I think that's why in the field of oncology, we have tumor boards where cases can be diagnostically and therapeutically challenging. And we bring together a whole group to review so you get kind of a consensus opinion.
Yeah, I love that, mapping out the person's personal sort of experience, and clinical history, diagnostic history, all of these things you're talking about, and sort of putting all of the puzzle pieces together to come up with a plan. Another question, and I think it's relevant within and outside of this specific biomarker, but are there any newer treatment options available or inactive testing for use when an EGFR positive non-small cell lung cancer becomes resistant to Tagrisso?
Yeah. So EGFR mutations we see in about 15%, 10 to 15% of our non-small cell lung cancer cases. This is one of the more common molecular abnormalities, molecular targets. It is one of the greater success stories in that because we've been able to target that abnormality for longer, we've been able to improve our drugs. Tagrisso or osimertinib is one of those drugs that has about a 90% chance of working when we see an EGFR mutation. This is a case where doing molecular testing after the osimertinib stops working can be important because the types of changes that we may see in the molecular testing when there's resistance might be a new abnormality in EGFR that responds to a different EGFR inhibitor. Even though the osimertinib is the latest and greatest, sometimes the older ones work in resistant cases. And then sometimes, and this is true not only for EGFR, but other types of targeted therapies in lung cancer, sometimes after your initial targeted therapy, your resistance happens because you have an abnormality in a different target. So it's complicated. You can't predict these things, and that's why we look. And
Yeah,
then finally, I would just close to say that even though EGFR targeted therapies have been approved now for over a decade, we're still developing new ones all the time.
yeah, and I think it points back to the importance of, and I say this all the time to our community, the importance of, at minimum, getting a second opinion with someone like you who is able to specialize and pay attention to what's happening right now in lung cancer. It's a challenge, and I think an unfair expectation, in my opinion, for a general oncologist, particularly working in some of the more rural areas, to know everything there is to know about whatever type of cancer, solid tumor or blood cancer, that walks through the door, because things are happening so fast and furiously. So I know we always recommend folks, if they can, to get second opinions with experts such as yourself, that will then go back and work with local doctors to ensure that best possible care for them is happening at their centers. So we've got about 10 minutes left, and I do want to jump into chemotherapy and radiation therapy. Can you help go to sort of dispel this myth there is about chemotherapy? I know folks tend to think about their grandfather or great grandfather's chemotherapy, and how sick and how poor the quality of life was. Why is chemotherapy still a good drug to use to treat cancer?
Well, so, Danielle, I expect that a lot of people listening tonight would be shocked to hear me say that oftentimes chemotherapy in 2022 can be better tolerated than targeted therapy, but it's the reality. Remember that targeted therapy, these pills are usually taken every day, number one. Number two, if you're going to take a drug every day, then you're going to have side effects every day. So even if the side effect is mild, knowing that it's always there can affect quality of life. And targeted therapies can have real toxicities. They can. So what's happened with chemotherapy? Well, we talked about how targeted therapies work. They hit a specific molecule. How do we know what their toxicities are? Well, if that molecule or something related to it is also present in normal tissue, like EGFR being in the skin or in the intestine, you might get rash or you might get diarrhea. Immune therapy toxicities happen because you unleash the immune system on the cancer, and you might also unleash it on normal parts of the body. And granted, most people don't get serious autoimmune side effects, but they're totally unpredictable. We don't know who's going to get it, when it's going to happen, or which organ it's going to be. So let's think about what causes the side effects of chemo. Well, when you give chemo IV, how does the chemo know to go to the cancer? Chemo is programmed to target things that are dividing and growing. And cancer cells are dividing and growing more than most of the body is. Right? At any given time, most of us aren't getting taller at this point in our lives, although we might be growing in other ways. But there are normal parts of the body that continue to divide and grow at adulthood. Our hair, and that's why hair loss can happen with chemo. Our GI tract, the lining of the cells in the stomach and the intestine, which is why nausea and vomiting can happen. And the cells in our bone marrow are always dividing and growing and being replaced. And that's why you can get low blood counts. We've gotten so good at preventing side effects. The most commonly used chemotherapy combination in lung cancer doesn't cause hair loss. And with medicines that we have to prevent nausea and vomiting, fewer than 5% of my patients who get chemotherapy ever throw up now. And if they do get nausea, it's not every day. It would be a couple of days after chemo that's given once every 3 weeks or so. And the dangerous blood counts that we used to see with chemotherapy, we can often prevent with injections of growth factors to keep the blood counts high. Now, there are some chemotherapy regimens that are really well tolerated, yet still quite effective. But just as we might switch targeted therapies when there's resistance, when we go on to use subsequent types of chemotherapy, they may have more side effects than the ones we use initially. But the reality is that chemotherapy can be really effective in people. It can be helpful for stage 1, 2, 3, and 4 lung cancer. It may be used by itself, after surgery, before surgery, with radiation, or with immune therapy. Lots of ways that it can be used. And I would say that if there's someone who has a lung cancer diagnosis, assuming they're not critically ill with other diseases, it would be a real disservice for them not to ever get chemotherapy. Because remember that the emergence of new treatments for people who qualify, like targeted therapy, isn't to do something instead of other options. It's to do something in addition to other options. It's giving us another arrow in the quiver. That's what it's doing.
That was absolutely fantastic, and I think the supportive care that you touched on is relevant across all of these therapy types, right? And I know we also constantly are pushing out to our community that if they haven't been connected with someone in the palliative care realm, and I know that's another sort of taboo word because people automatically associate that with hospice or end of life care, which isn't necessarily the case. It is supportive
Correct.
care. I think it's also important because I know I've known way too many patients over the years who, although are suffering from some pretty debilitating side effects, are afraid to tell their healthcare teams about it for fear of coming off treatment. When in reality, the probability of actually getting help for those side effects and maintaining your treatment is there, but you have to say something. So
Yeah, I can't stress enough the importance of supportive care. And, pharmaceutical companies put a lot of ads into immune therapy, millions, billions of dollars in their advertising budgets, and Nobel Prizes get awarded for immune therapy. You know what? I'd love to see the Nobel Prize for anti-nausea medicines. I would.
yeah,
It has changed. It has changed the field of oncology for every cancer diagnosis, night and day
yeah.
compared to what it was 25 to 30 years ago.
I could not agree with you more. Sadly, I think quality of life, at least in some respects, has been sort of an afterthought as opposed to something that folks should be thinking about and having conversations with their healthcare teams about from day one. So we've touched on a lot of this, and I know we've given sort of this 30,000-foot view, and everything that we've talked about tonight, from biomarker testing to the different types of therapies, targeted therapies, immunotherapies, chemotherapy, radiation therapy that we touched on in the combination space, in the treating brain metastases space, could be a living room all on their own. So please stay tuned for the rest of the meetings and the calendar coming out for the rest of this year, because we're going to be doing exactly that, breaking a lot of this out, and having deeper dive conversations into some of these areas. But one area that I wanted to make sure that Dr. Gerber gets to touch on, because I know it is near and dear to his heart, before we close, his sort of final thoughts around screening and prevention. And this will point back to an earlier question that came in, that I think now would be a perfect time to maybe discuss. Is, how can we say there definitively is not a genetic or an inherited attribute to lung cancer when there are multiple families who have several family members who have received a lung cancer diagnosis and passed away from it. So where does screening sit now? What do we need to do you know, to expand on what the current criteria is, and what is your message to folks about, not the ones necessarily watching tonight who clearly most of whom have already been diagnosed, but what can they do in their own communities with their own family circles and their friend circles to help spread the word about the options available right now?
Yeah. So the United States Preventive Services Task Force, which is the government branch that approves cancer and other types of screening modalities, um, believe it or not, approved lung cancer screening 9 years ago. Which is, it's just amazing that it's been a decade already. And despite that, fewer than 5% of Americans who are eligible for lung cancer screening undergo screening for lung cancer. And there are lots of reasons for that. Who's eligible for lung cancer screening? Um, Initially, it was adults 55 and older who had smoked 30 pack years of cigarettes. So 30 pack years is a pack a day for 30 years, or any other way that you get to a total of 30. Um, we realized recently that certain patient populations got lung cancer with less smoking. So if you're African American, you get lung cancer with less cigarette exposure than you do if you're white, about half as much. And so the government recognized that. And last year, they changed the recommendation. It's no longer 30 years of smoking, it's 20 years of smoking. And they dropped the age from 55 to 50. What is the test? It's a low dose CT scan. It's about 1/5 the radiation dose of a standard CT scan. How long does it take to do? The patient goes in, lies down in the machine, takes a breath, holds it, and exhales, and they're done. It's done in seconds. And there's no contrast. You don't need an IV placed, and there's no risk of an allergic reaction or anything like that. One of the issues is that we know that there are a lot of people with lung cancer, though, who still don't meet those criteria. Maybe they're younger than 50. Maybe they were never smokers, especially when we talk about people who have molecular targets. And we know that 15% of people with lung cancer have never smoked. And they didn't necessarily work as coal miners, and they didn't necessarily work as bartenders. So we don't have an obvious environmental reason for why they got lung cancer. We don't know why they got lung cancer. Even if we find a molecular target like EGFR, we don't know why that happened in that person. And there may be a genetic component to it. And we need to get better at identifying who are the people who may ultimately be at risk for getting lung cancer, so we can start thinking about prevention and screening those individuals as well.
Yeah, thank you for that. I think I always like to tell folks that although it might not be relevant to you, it might be relevant to someone you love or to your neighbor or to your checker at the grocery store. And I agree that, it is what it is right now, and we'll take it. We're grateful for it. Roughly in this country, I think um, 16 million people currently qualify for low dose CT screening for lung cancer. And to your point, 5% is not enough, because if we can catch it early, that's when we have the most likelihood of curing it. So spread the word, my friends. Speak from the mountaintops, and let folks know how important screening is. Just like your mammogram or your colonoscopy, it is there and it is available. I thank you so much, Dr. Gerber, for coming and talking with us tonight. It has been a wildly exciting conversation for me. I'm sure for our lung cancer community who was able to come in and join us tonight, and for those who will come back and watch post live. Thank you all so very much. A huge thank you to Penn Media, everyone watching, my go-to organization, the go-to foundation for lung cancer, and everyone on staff who works so diligently day in and day out to help improve outcomes for people diagnosed with lung cancer. Huge thank you to you all. And of course, to our supporters. Without their support, we could not bring you this educational programming. So thank you to Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Thank you all so very much for continued support, and hopefully we'll see you all next month. Thanks for joining.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.